common in TB case conferences, and I'm glad we have the opportunity again to revisit issues surrounding TB and HIV co-infections, particularly hopefully discuss ways we can mitigate the negative effects of immune reconstitution as we treat these patients. It's a pleasure for me to introduce today's speaker, Dr. Eric Beeler. Dr. Beeler is a pulmonary critical care specialist at the Allegheny General Hospital, and he is also the medical director for the Allegheny County TB Control Program located in Pittsburgh. He has been a frequent collaborator with GTBI, and we're glad that he is presenting his case for us today. So without further ado, Eric, you have the mic.
Okay, thank you very much, Dr. Larenzabal. Is the volume okay?
Yes, sounds good.
Okay, great. So like Dr. Larenzabal said, my name is Eric Beeler, and I am a pulmonary critical care physician here in Pittsburgh, Pennsylvania. And thank you all for joining. I know it's a really hard time to carve out extra time, so I definitely appreciate your input on this difficult case. As I said, I'm a pulmonary critical care physician. I am not an infectious disease specialist, so I certainly don't claim to be an expert in HIV. So for any infectious disease specialist on the line, please take mercy on me. But I would like to go over a very complicated case that we've had at the Allegheny Health Department over the last few months. And it involves a case of HIV-TB co-infection. So first, we're going to start with the case presentation, and then I'm giving away my diagnosis here, but we're going to go over the definition of IRIS. We're also going to go over the incidence and manifestations of IRIS, and we're going to discuss possible preventative strategies and treatment of IRIS. So our gentleman was a 21-year-old male who had originally immigrated from Kenya in 2017 to attend college in a city north of Pittsburgh. And when he came into the country, he had a positive coronavirus. And there was a possible treatment with 4 months of rifampin. However, the patient wasn't able to give very good details of this, and the documentation from our sister health department left a little bit to be desired. So I can't say this was truly taken. Another very important piece of family history is his mother actually died due to AIDS complications in Kenya in 2013. And when he came back to the Pittsburgh area to visit family in May, he was seen at a local urgent care with constitutional symptoms consisting of weight loss, night sweats, fever, and diarrhea. Now, both he and his family were very familiar with HIV, so they actually requested HIV testing at that time. And he was found to be significantly viremic and also significantly immunosuppressed with his CD4 count of 40. So at this point, he was referred to one of our local HIV clinics, and they did an in-person examination on him. And at that time, he was afebrile, cachectic, very thin, ill-appearing. But there was no other reported abnormalities seen on physical examination at that time. They did their standard battery of testing, given his symptoms. And the most identifiable one that we're going to talk about is his quantiferin gold, which came back positive. Also of note, he had been COVID tested twice by this time, and he was negative on both occasions. So at this time, he was started on Biktarvy, and then he got referred to us at the health department for evaluation of his quantiferin gold. So approximately 7 days later, he came to the Allegheny County Health Department, and he was febrile to 102, tachycardic. I've been working in the health department for about 10 years, and he was the most toxic person I've ever seen walk in there. He appeared like a septic ICU patient. He was confused. He was not able to give history or his medications or what had been going on with him recently. Despite that, his examination was non-focal and he did not have exhibit any meningeal signs at that time. However, on examination, he had tremendous right-sided cervical adenopathy, which was not documented previously. And we did our chest x-ray, which we'll look at in a second, which is relatively clear. And given that we are a tuberculosis clinic, obviously our suspicion was extremely high for tuberculosis. But due to the patient's acute illness and inability to produce sputum, he was directly admitted to a local hospital for workup. And, as I stated previously, this is his chest x-ray. I hope it projects well on your screen. So there is possibly a minor right basilar abnormality. There is some blunting of the costophrenic angle with some very minor infiltrates in that area. And there's also a possible hint of some adenopathy, particularly in the left hilar region. And if I wanted to get real imaginative with this, I could say there might be some subtle nodularity, but for the most part, the chest x-ray was underwhelming. So this is a representative slice of his CT scan of the neck. And as you can see, he has tremendous adenopathy, which is quite large and multiseptated with a necrotic appearance in some of the lymph nodes. And this is a representative slice of his CT scan of the chest at that time. And once again, there is some left hilar adenopathy here and some minor, very minor, very subtle nodularity changes, but not enough to, in my opinion, to call a miliary pattern on this CT. So part of his workup then began, and it started with a right cervical lymph node biopsy, which showed essentially just extensive necrosis. They did try to send it for flow cytometry. Unfortunately, there was not enough material to do this. The smear showed many AFB, and eventually the culture came back as Mycobacterium tuberculosis. He also had left groin adenopathy, which was also biopsied. And from a cytology standpoint, this was largely non-diagnostic. And his smear status on that biopsy, was negative, but eventually the culture did grow MTB as well. Also, he had three sputum smears, which were negative, which eventually came back culture positive for Mycobacterium tuberculosis. He underwent an extensive opportunistic infection workup, which was negative at that time. So he was discharged on rifabutin, ethambutol, PZA, isoniazid, Bactrim, and his Biktarvy was changed to Tivicay and Truvada. He then followed up with us again in the health department approximately 2 weeks later. He was more alert. He was afebrile at that time. Unfortunately, he had developed a very severe neuropathy. He was having difficulty with ambulating. He was ataxic. He had decreased sensation up to the knee bilaterally, symmetrically, and he had decreased proprioception. Now, obviously not while he was at the health department, but he was referred to neurology, who felt that he had an idiopathic neuropathy, possibly related to his HIV, his immunosuppression, his cachexia, his HIV meds, and of course, the tuberculosis meds were also brought up. And he had undergone an MRI brain and spine. The MRI spine and the cervical region redemonstrated his impressive adenopathy and cystic mass. But otherwise, there was no issues in regards to his spinal cord or brain parenchyma, or no abnormalities seen. Due to the abruptness and how rapid his neuropathy had progressed, it was decided to substitute Levaquin for isoniazid, and his B6 was increased to 100 milligrams at that time. So 2 weeks later, he comes into the health department with a new onset because he had defervesced, high fever. Unfortunately, his neuropathy symptoms were unchanged. His adenopathy had actually gotten larger, and he had developed a fistulous tract to the skin. His chest X-ray, which we will look at in a moment, showed a new miliary pattern. Unfortunately, he continued to have significant weight loss and failure to thrive. And unfortunately, also confounding the situation when his isoniazid was discontinued, unfortunately, his ethambutol and PZA were inadvertently discontinued as well. So unfortunately, he was only taking Levaquin and Rifabutin for approximately 2 weeks. Once again, due to his rapidly progressive nature, he was readmitted to the hospital. We had, between the fact that he had potentially had been exposed to rifampin in the past and the inadvertent drop of both PZA and ethambutol, there was concerns for drug resistance. We also had concerns for potential underlying drug reactions, opportunistic infections, and iris as well. So this X-ray, in my opinion, is not very subtle compared to his initial chest X-ray. I feel very comfortable that a new nodular pattern has set in throughout both lungs, consistent with a miliary tuberculosis pattern. So during his second hospitalization, despite the fever and his clinical status, he did not have a lot of respiratory symptoms, or new respiratory symptoms, I should say. He was able to give 2 sputum specimens, which at that time were smear negative and eventually became culture negative. He also had AFB blood cultures, which were also negative. Of note, his HIV viral load, which was approximately 6 million, had become undetectable this was over about a 6 to 8 week period. And his CD4 count, which was initially 40, had gone up to 70. He had also undergone another opportunistic infection workup, which was unremarkable. There was concerns for potential underlying secondary bacterial infection given the drainage coming from his neck, but this also was unremarkable. And he was COVID tested for, I believe, the 4th time, which was negative. So at this time, he was discharged and he was started on rifabutin, or he was continued on rifabutin. His pyrazidamide and ethambutol were restarted and Levaquin was continued. Azithromycin was added for the possibility of a disseminated MAC infection, although there wasn't strong evidence of this. And he followed up in the health department. Unfortunately, over the next few weeks, he continued to have daily fevers as high as 104 with no rhyme or reason. He'd have a fever of 104 and say he felt fine. It was quite an interesting experience. And unfortunately, he continued to have night sweats. He was not gaining weight and responding the way we would have hoped. We did have his original culture, which we sent to the CDC for an MDDR, which did not show any mutations which would confer resistance. And eventually his DST did come back, and despite his pre-treatment or potential pre-treatment with rifampin, he was found to be pan-susceptible. Second line testing was also performed, and he only showed resistance to streptomycin. So at this time, our working diagnosis was likely iris, given that we were not able to document any definite drug resistance. There was no evidence of drug reaction, and he had been worked up for opportunistic infections other than tuberculosis on multiple occasions, which were negative. And we had started him on prednisone, 40 milligrams for 2 weeks, followed by 20 milligrams for 2 weeks. This did lead to an improvement in his fevers and adenopathy, and it was also associated with significant weight gain. Unfortunately, once the steroids were tapered, his symptoms did recur, although not nearly as significant as they were previously, and he required another 2 weeks taper at that point. Okay. And, this is his most recent chest x-ray, which was performed a few weeks ago, which in my opinion shows a very, a significant improvement in regards to his nodularity. I do think there's still a hint of adenopathy in the left hilar region, but overall definitely improved. And his clinical status has definitely improved as well. So, before we start talking about Iris, I would love to hear anybody's comments. I've worked at as I said, I've worked at the health department for 10 years. We in Allegheny County, we don't see a whole lot of co-infection. And I certainly haven't had anybody this immunosuppressed come into the office recently. Or ever, to be perfectly honest with you. So I was pretty taken back by him and how acute and how his appearance. I was very impressed. And I'm just curious if anyone else has any other thoughts or any other concerns regarding management.
Yeah. Thanks, Eric. I mean, I do have a few thoughts, and I'd like others on the line to please feel free to unmute and pitch in your thoughts. But I'm impressed by the response to the antiretrovirals over just a few weeks, 6 weeks or so. You go from millions to undetectable. That's really amazing.
Yes.
I was wondering whether the early manifestations of neuropathy and ataxia and all that could be possibly due to acute HIV as well. And I'm hoping some of the ID folks can kind of weigh in on those thoughts.
It was certainly a concern of the neurologist that we had sent him to. He left it very open-ended as far as what he thought could possibly be contributing. And also, more than likely, it was multifactorial, because the gentleman was also quite malnourished as well, in addition to everything else he had going on.
Did the neuropathy improve?
Yes, it has. It has taken time, and it is not completely resolved, but he used to have to come in with a walker to get into the office, and now he's ambulating freely on his own. He still does have some paresthesias. He still does have some pain, for which he's taking, I believe, Lyrica for, but the neuropathy symptoms have improved as he has improved.
Quite dramatic. You can go ahead, and perhaps we'll have time to talk further after your presentation.
Okay, that's great. So when it comes to the definition of iris, there was a paper put forth by, and I'm going to destroy his last name, but Mengentes in 2008, which, as I was doing my reading and research, is the definition that is used in all papers going forward. So we're going to take a little bit of time and go through that. And, so iris, I know this crowd doesn't need me to tell you what iris stands for, but it is the immune reconstitution inflammatory syndrome. And it is a result of immune recovery towards tuberculosis specific immune responses. And unfortunately, this leads to inflammation where TB antigens still exist despite treatment. And all of this inflammation and this attack of the immune system leads to a paradoxical worsening or unmasking of tuberculosis manifestations. Now, although TB iris is a very well-known and has its own diagnostic criteria, this iris is not isolated just to tuberculosis and can be seen in other infections such as herpes and deep fungal infections such as cryptococcal meningitis. There are two separate forms of iris, the most well-known and best studied form is certainly paradoxical tuberculosis-related iris. There is another form of unmasking TB with subsequent iris thereafter. One of the challenges of this disease is, there is no diagnostic test that can say, yes, you have, or no, you don't. So that definitely makes, and with patients this sick, there's always going to be a very wide differential, which makes that challenging. And previous definitions to this paper did have a change in CD4 count or plasma viral load, or even response to PPD in their definitions. But unfortunately, in Africa, sub-Saharan Africa, where co-infection is probably the most prominent, a lot of these things are not readily available, and definitions using these criteria are not going to be feasible. Okay, so I just copied and pasted this, obviously, from the paper. We're not going to read through the entire, but I think we can go through the highlights. And, for the definition of paradoxical iris, there's 3 domains. So obviously, you need a diagnosis of tuberculosis prior to starting antiretroviral therapy. Ideally, there should be a response to tuberculosis treatment. In this day and age where we're starting antiretroviral therapy early, there may not be a complete response in regards to tuberculosis, but ideally, the patient should be getting better from a TB standpoint. Then there is the clinical criteria. So from a clinical standpoint, most of these manifestations should be present within 3 months of initiation of antiretroviral therapy. And there are major criteria, which are enlarging lymph nodes, cold abscesses, or new or worsening radiographic features of tuberculosis, particularly in the chest. Also, new or worsening CNS tuberculosis or new or worsening serositis. Minor criteria include constitutional symptoms, respiratory symptoms, and worsening of abdominal symptoms secondary to abdominal involvement. And the final domain is essentially ruling out any other alternative explanations, such as drug resistance, poor adherence, opportunistic infections, and drug toxicities. Now, unmasking of TB iris is a little bit more vague, or I shouldn't say vague, but it certainly is not as well described or not as well studied, let's put it like that. And, they break this into 2 categories: ART-associated tuberculosis, which is essentially diagnosing tuberculosis after the initiation of ART therapy. And then unmasking of tuberculosis-associated iris is the tuberculosis developing after antiretroviral therapy with a heightened inflammatory response. And they particularly say TB lymphadenitis, abscesses, and these patients can actually present quite dramatically with respiratory failure and ARDS. Now, I do believe the patient in this case presentation probably fits into this category. Now, I do not think his respiratory compromise was nearly to the point of ARDS by any stretch of the imagination, but I do believe he does fall into this category, and he also meets the last bullet point that his clinical course has been complicated by a paradoxical reaction as well. So when we're talking about the incidence and manifestation of iris, there are 3 major trials which were paramount in determining how we start antiretroviral therapy in the setting of HIV. I am not going through those trials. I am going through the planned secondary analysis, which were specifically looking at the iris complication. And the first study that we're going to review is the STRIDE study. And as I said, it's a planned secondary analysis. And this was an open labeled randomized trial of early antiretroviral therapy versus later antiretroviral therapy initiation in the setting of newly diagnosed tuberculosis. Their inclusion criteria was a CD4 count less than 250. The patients in this study did have a median CD4 count of 77. As far as tuberculosis was concerned, they did allow for a clinical diagnosis of tuberculosis, including extrapulmonary tuberculosis. Of the 806 patients that were in the study, 61 or 7.6% developed iris. The overwhelming majority of the cases did present within 4 months of initiating therapy for tuberculosis. Now, those that were randomized to the early antiretroviral presented earlier at 29 days on average, and those in the later presented 82 days after initiation of tuberculosis therapy. The duration of iris symptoms was approximately 3 months, and there were no deaths that were directly attributed to iris. And the take-home point of this study, and a very common theme seen in the other two studies as well, is the incidence of iris goes up significantly when you have a CD4 count less than 50 and they start retroviral therapy early. Now, I am certainly not saying this to caution anybody to not start retroviral therapy early, because this is also the same group that shows the most mortality benefit from early initiation of antiretroviral therapy. But I definitely think it does provide a little bit of caution, or at least raise your senses to be aware of this and be ready for it. Now, when it comes to how the patients in the STRIDE study presented, the majority, both in the early and late group, met at least one major criteria, and it was the same criteria we went over previously. In the STRIDE study, lymphadenopathy was the most common presentation, followed closely by radiographic features, and not as commonly serositis or CNS tuberculosis. As far as the minor criteria, constitutional symptoms was most common, followed by respiratory symptoms and fewer abdominal pain. Also very interesting in this study, 54% were treated with steroids, which is definitely a higher number than we will see in the subsequent studies. And although there is not a high mortality associated with this disease, there is definitely morbidity. 35% required a procedure of some sort, whether it was a drainage of an abscess, etc. And 31% did require hospitalization. So once again, not a high mortality disease, but definitely associated morbidity. So SAPIT is the next study that we will look at. And once again, it was a planned secondary analysis. And what they did was they randomized 642 patients to antiretroviral therapy within 4 weeks of starting TB therapy versus 4 weeks of completion of the intensive phase versus 4 weeks of completion of TB therapy. Now, their CD4 count criteria or inclusion criteria was less than 500. They had a median of approximately 150 in regards to their CD4 count. Unlike the STRIDE trial, they did their TB inclusion was smear positive sputum. So these were predominantly pulmonary tuberculosis cases. Also of note, after a planned secondary interim analysis for safety, all patients who were randomized to start antiretroviral therapy at the completion of tuberculosis therapy were immediately started on antiretroviral therapy because of the mortality benefits seen with integrated therapy. Also, a little bit different compared to STRIDE was their criteria for iris. They did use an increase in CD4 count as a part of their criteria for iris. They did retrospectively apply the guide or the definition that we had gone over previously, and the majority of patients met the definition in addition to the CD4 count. Of the 642 patients, there were 80 cases of iris, giving a percentage of 12. Similar to the STRIDE trial, the early integrated group had the highest number of patients with iris of 43, with similar numbers in the late to integrated and the sequential treatment group. And also very similar to the STRIDE cohort, the patients who had a CD4 count less than 50 had a significantly elevated risk of iris compared to those in late and the sequential group, with the early group having a 45.5 per 100 person years incidence of iris. However, in the group that had a CD4 count greater than 50, the numbers were fairly similar. Now, by numbers, the early group did have a increased risk of iris, but this was not statistically significant. And one of the conclusions that the authors from this paper came to was in those patients with a CD4 count greater than 50, there was no survival benefit seen with early antiretroviral therapy. However, there was a twofold increase of iris. And now this is a Kaplan-Meier curve, which is essentially showing us what we just talked about. In the early integrated group, the probability of iris was significantly higher and obviously happened at a much earlier time than the late and sequential treatment arms. The thing that is interesting is both the late and sequential arms had the same probability of iris over time, which I found interesting. And in regards to the manifestations of iris in the SAPIT trial, once again, the number of patients were obviously higher in the early integrated group. They had more severe grade reactions compared to the late and sequential. They did have a significantly higher hospitalization rate. One thing that is a little bit different than STRIDE is very few people had received steroids in comparison. But the other revolving theme with these studies were the complete resolution of iris. And although, like I said, there's definite morbidity associated with this disease, but complete resolution is very common. And as far as mortality is concerned, once again, there was only 2 deaths in the entire study directly related to iris. So low mortality, however, is associated with significant underlying morbidity, with overall what seems a very good prognosis. Now, this is a bar graph of the presentations that was seen in the SAPIT trial. If you recall, their inclusion criteria from a tuberculosis standpoint mandated a positive smear. So it's not surprising that their iris manifestations were predominantly pulmonary, with respiratory symptoms and pulmonary infiltrates being by far the most common things leading to presentation. Okay, so the final study we're going to look at as far as incidence and manifestations are concerned is the Camellia trial. Once again, it was a planned secondary analysis, and they enrolled 661 patients, and there was 597 available for the secondary analysis. The design of this trial was antiretroviral therapy 2 versus 8 weeks after initiation of tuberculosis treatment. Their inclusion criteria for CD4 count was less than 200, and their median CD4 count was 26. So this was definitely a more immunosuppressed population than the other 2 studies. Also, they did require a positive culture or smear, and they did allow for extrapulmonary cases as well as disseminated cases of tuberculosis as well. And not surprisingly, their percentage of iris was significantly higher. Of the entire group, 155 had developed iris, which is a total of 26%. Once again, the common theme being common, the early group did account for the majority, or 36%. They also found increased risk with low CD4 count, but also in patients that had extrapulmonary or disseminated disease, they felt had a higher incidence of iris. And also those that were significantly viremic also had a significant increase in iris as well. The median time to development of iris was 14 days, with the majority of people presenting within the first 3 months of antiretroviral therapy. And once again, duration of symptoms was approximately 7.4 weeks. There was a slightly higher number of deaths in this study directly attributed to iris, although not very high, but there was a little bit more mortality associated in this study. And, similar to the STRIDE trial, which also allowed for extrapulmonary inclusion of tuberculosis, the study authors, the study investigators, and Camilla found that lymphadenopathy was the most common presentation in regards to iris, followed closely by fever, and not as commonly GI or neurologic manifestations. Also very common were chest x-ray findings at 65%. And as far as treatment was concerned, the majority of the people that were in this study received some form of treatment. There was a significant percentage of patients who received NSAIDs, and as well as steroids, and even a more significant number of people who received a combination of NSAIDs and steroids. And as said before, the cure rates, once again, are very good. Even in the sicker group, the cure rates of iris were about 91% and 93% in the overall study population. Okay. So before we move on to discuss treatment and prevention, does anyone have any comments as far as incidence, manifestations, or their own personal experience? As I said, as a pulmonary critical care physician, I do not claim to be an HIV specialist, so I don't see a lot of co-infection. So does anybody else have any thoughts or anything else they'd like to share?
Yeah, hi, Eric. This is Henry Fremow.
Oh, yes, thank you, Dr.
Yes,
Fremow. You have
I
saved me
think,
with this case.
well, the group collectively has helped out in, so we don't, I mean, obviously we see much less TB iris here in the US, but we see a lot of iris in our advanced HIV patients, most commonly MAC, but we'll see it from Cryptococcus, we'll see it from a variety of other things. And they can, in some patients, this can be extremely difficult to manage. And it's sort of like we have crude tools in that we're using steroids for management. There's been a lot of work looking at the sort of components of the inflammatory response in TB-associated iris. And maybe as we sort of have learned a lot more about more subtle approaches to immune modulation from treating COVID inflammatory responses, some of that may be applicable to TB. I mean, the most consistent elevated cytokine in these folks seems to be IL-6, and which sort of we never even used before as something that we were looking at, but now most of us have labs that can measure that. But even following the C-reactive protein seems to be a good marker, and also helps distinguish that from things like drug fever and some of the other manifestations that might be in the differential and sort of point to that severe inflammatory response. But real nice job with your presentation, and
we got a
I
couple
think
more
that you've
slides.
covered. Yep, I think that you've covered most of the presentation stuff. I'm interested to hear what you have to say about treatment.
Okay, great. Yes, no, thank you. And thank you all very much. Your support through this case has been immensely appreciated, trust me. So moving on, as far as when it comes to iris, we're going to touch on prevention and also treatment of iris, or what there is out there. And the first thing we're going to talk about is a study that came out of New England Journal in 2018 that actually looked at a regimen to try and prevent iris. So this was the PredArt study, and it was a randomized double-blind placebo-controlled trial of 240 patients. Its inclusion criteria was a CD4 count less than 100. They did allow for both confirmed and clinical diagnosis of tuberculosis, and they had to be started on antiretroviral therapy within 30 days of initiation of tuberculosis therapy. And they used a regimen of 40 milligrams of prednisone for 2 weeks, followed by 20 milligrams of prednisone for 2 weeks. And what they found was there was statistical significance in regards to the decrease incidence of iris in the prednisone group. There was some trends towards improved outcomes as well, including definitely less open label glucocorticoid use and decrease in the raw number of hospitalizations, both for iris and any cause, with similar death. And I think the other thing, because obviously I get very concerned. You have someone so immunosuppressed and you're going to give them prednisone. Just saying it out loud makes you a little bit worried, just from an infection standpoint. And the interesting thing is they did not see a significant increase in regards to severe infections or overall infections in the prednisone group. And if anything, there was actually some trends towards improvement as far as adverse outcomes were concerned, suggesting that maybe there was an anti-inflammatory effect to some drug reactions that the prednisone was helping with. And also I think that's important, is they looked at are we affecting the immune recovery with using prednisone, and they looked at CD4 counts at week 12, which were similar, and they also looked at the viral loads 12 weeks out too, which were also very similar. So it seems like a safe-ish thing to do. Obviously, like I said, saying it out loud, it gives me a little bit of concerns further upfront, further immunosuppressing these patients, but it certainly did seem to help in regards to iris. And also I found this interesting as a pulmonologist. The same study group did a sub-study looking at the effect of iris and prednisone on lung function. And they took 153 patients from the PredArt study group, 77 in the prednisone group and 76 in placebo. 71 of these patients had developed iris, 30 in the prednisone, 41 in the placebo, and 46 had received open label prednisone, with the numbers that you can see there. And what they did was they looked at symptoms, 6-minute walk test, spirometry, and chest x-rays at week 0, 4, 12, and 28. And what they found was kind of interesting, and not terribly surprising. The mean 6-minute walk distance and the mean FEV1 and mean FVC were all better at 4 weeks, as far as there was a improvement from a prednisone standpoint. But the thing that was also interesting was when they repeated all of these studies at 28 weeks, that improvement had waned. So it does seem that the prednisone does have a short-term benefit in regards to lung function, but not a definite long-term impact as far as in the future. And a very similar story for iris itself. Just the development of iris did lead to a decrease in 6-minute walk distance, as well as a decrease in FEV1 and FVC percent predicted. And over time, the people who developed iris caught up to those people that did not have iris, and they very similar numbers at week 28. So the authors concluded from this study, although abnormal lung function is a very common problem in patients with HIV and co-infection with TB, that using prednisone or the presence of iris did not seem to impact that significantly. And when it comes to treatment, this is this is it. There is only one randomized controlled trial that I was able to find, and I apologize if there are more, since I'm saying it a little sarcastically. And it was a randomized controlled trial of 110 patients with documented paradoxical iris, and 55 were in a 2-week prednisone 1.5 milligrams per kilogram per day, followed by 2 weeks of 0.75 milligrams per day for 2 weeks versus placebo. And their primary endpoint was days of hospitalization and outpatient therapeutic procedures over the 12-week study period, with secondary endpoints looking at TB iris symptoms, health survey questionnaires, looking for steroid complications, documentation of new infections, and chest x-ray changes. And, they met their primary endpoint in the prednisone group. They had a median of 0 cumulative hospital days and procedures, whereas control had 3. Their secondary endpoints also favored prednisone use as well. In regards to infection, there were more infections seen in the prednisone group in comparison to placebo. But when it comes to severe infections, they were pretty similar between the two groups. And the author said that a lot of the infections in the prednisone group were related to like oral candidiasis and things that were fairly manageable. Quite a few patients did receive open label prednisone, more so in the placebo group. Death, once again, was not a common thing. But the other thing that I found very interesting was that 10 patients in the prednisone arm needed to be retreated after the 4-week course. And they said some were on prednisone for several months. So it's hard to say that prednisone is a one size fits all, or I should say the dosing and or duration is a one size fits all, or the exact regimen is known. And, that's kind of reflected in the guidelines. These are 2 of our US guidelines. So in the guidelines for the prevention and treatment of opportunistic infections in adults and adolescents with HIV, they give a B recommendation for steroids for treatment of iris, and they quote the same regimen that I just presented. In regards to prednisone for prevention, they also give that a B recommendation using the inclusion criteria used by the PredArt study. And they gave a C recommendation for things such as NSAIDs and abscess drainage. And now from the 2016 ATS CDC IDSA treatment guidelines for drug susceptible tuberculosis, they mentioned that for patients who develop iris, prednisone may be given at 1.25 mg per kg per day with a dosing range of 50 to 80 milligrams per day for 2 to 4 weeks, with a tapering over a period of 6 to 12 weeks or longer. So unfortunately, not terribly specific. And then in regards to treatment of unmasking iris, which, like I said, I think that's where my patient lies. Once again, and I apologize if I didn't say this earlier, all of those studies that we had gone over were paradoxical iris, TB-related iris. None of them actually, there isn't a lot of randomized control trials and or studies looking at unmasking of virus. They do, from the guidelines of prevention and treatment of opportunistic infections, they do recommend steroids for life-threatening, but they do mention that there is no real clinical trial evidence to support their use. But that's what I have. So thank you all very much for your attention. I would love to hear any questions or comments or suggestions or offers for this patient to move to your county. I am more than willing to hear them now.
Thanks so much, Eric. I had a question about the patient specifically, and whether he got his HIV through his mom. Do we know anything about the perinatal?
Yeah, the suspicion was for vertical transmission. He was sexually active with only one person, and he predominantly wore condoms, and this was in the United States, per him. So the thought process was it was vertical transmission.
Okay. And let's review this again. Most of the recommendations for prophylactic prednisone seems to be after you diagnose TB, you find out they're HIV positive, and it's less than 50. What they're saying is start them or treat them with prednisone alongside everything else. Is that
Yeah,
accurate?
so at least my understanding from what I read in the guidelines, and I certainly don't want to be misquoting it, but as long as you are following the inclusion criteria from the PredArt study with a CD4 count less than 100, confirmed tuberculosis in ART within 30 days, that was their inclusion for the study. And this was the regimen they had used.
Mhm.
You know, the at least what I took from reading the guideline was it was something that you would consider. I got to be honest with you. And that's why at the beginning, I'm not trying to dodge any questions, but I am not an infectious disease or HIV specialist. But from reading through all of this, I really think you have to, personalized medicine and look at your patient, their CD4 count, their bacillary load from a tuberculosis standpoint, in making these kinds of decisions, as opposed to instituting prednisone on every person that might meet this criteria. But that's my personal feeling from reading through this, as opposed to true clinical experience, because this gentleman was, like I said, by far the most immunosuppressed person I've seen in the health department.
And the other side of the coin, HIV diagnosed and later you unmask TB, there's no recommendation with regards to
No,
this.
so this would be for the paradoxical tuberculosis associated iris, as opposed to unmasking. So trying to use prednisone, this regimen in my patient up front, I don't think would have been necessarily supported by the studies, because I don't feel he necessarily fits into this criteria.
Exactly. Henry, do you have any comments on the issue of how to approach these?
Yeah, I couple of thoughts. So first of all, I think that although steroids always are a little bit frightening, I mean, we have a long track record in HIV disease of using steroids for pneumocystis. And those patients get a couple of weeks of prednisone for their
It's true.
severe pneumocystis manifestations and advanced HIV disease, and the benefits there certainly outweigh um, whatever perceived risks there may be. So I think that the steroid part is, I don't think we need to be frightened. I think what we need to be frightened of necessarily is if it goes on, what the effects of more prolonged steroids might be. But I agree with you, Eric, that I don't think that I think these patients need to be individualized. And some patients seem to sail through, and others just have severe refractory iris related syndromes. And I think still don't know the best tools for monitoring response or figuring out how long they need to get their steroids or how slowly it needs to be tapered, or when there may be a role for use of other immune modulators.
Right.
Um, and we also see iris-related syndromes in the absence of HIV. I mean, we sort
Hmm.
of see similar syndromes in TB in patients whose TNF antagonists are abruptly stopped, and occasionally in transplant patients whose immune suppression is decreased in response to their TB diagnosis. Um, and again, I think that the optimal management in those patients is unclear. And I think the important thing is, and I think that's why the unmasking patients are more complicated, is that as long as you have them on an effective TB regimen that they're tolerating, then you have a lot more leeway to do things like add steroids. But the unmasking patients are presenting with their TB and inflammatory response at the same time. So you really don't have a handle on their TB disease. And that's why it's a little, more disconcerting to throw them on steroids right away.
So,
Just a couple of thoughts.
yeah, Henry, if in this case, the patient had certainly uh, AIDS and likely disseminated TB from the beginning, uh, it would it be of concern that it was disseminated and perhaps disseminated into the brain as well? And and
Yeah, I think that is a concern. I mean, our threshold to do an LP in patients like this, and certainly at least imaging, um, especially imaging at the time when they seem to be flaring everybody else, you're more likely to see something in the head if it's going to be there. Um, but yeah, I mean, there's no, and I think that CNS involvement is probably underdiagnosed in these patients,
Mhm,
and we also know that if they have CNS involvement and they have bad iris, those are the ones who do die.
right.
Um,
And,
so
and and so it will actually be good to kind of have your anti-inflammatories on board as long as you're not concerned about any other infections or
But
opportunistic infections.
and I was curious also because as I was reading, there was definitely certain concerns or spatterings of concern regarding steroid use in HIV and malignancy. And I was kind of not I'm not concerned in this case, but I was kind of curious how you all felt about that. If, not only from a
Yeah,
Kaposi standpoint, but
there's a PP did just walk in and it's for the shelter, so I cannot turn this guy away, you know.
Okay. All right, sorry.
I guess we know how she feels.
Say that again, Eric.
So I guess I was curious what everyone's thoughts were about the underlying possibility of malignancy in HIV patients that were treated with steroids, particularly Kaposi. And if I recall, the study regarding pericardial tuberculosis, which had enrolled HIV patients, there was a signal or there was a concern for possibly increased risk of malignancy. And I was just kind of curious. None of these studies saw that. It was mentioned in a lot of their discussions and they did not see it. But I was just kind of curious if anyone has concerns over that, like future malignancies.
Um, not that I am aware of, Henry. Are,
yeah, I don't think there's a strong signal for that. I mean, and there are a lot of patients with advanced HIV disease who end up getting steroids for a lot of different reasons. And I don't think that that's played out, that there really is an increased likelihood of things like lymphoma or other malignancies down the road. But we also don't always know what we're mucking with until a decade later. So
any other thoughts or questions from the audience? Oh yeah, Dr. Narayanan Navid just put on the chat box that there certainly is support for TB meningitis and steroid use, and that's a clear survival benefit. So how's the patient doing, Eric?
He's doing much better. He will still have an occasional night sweat, and it makes me start sweating. But no, but for the most part, he's been doing pretty well. The neuropathy has definitely improved. He had a tremendous weight gain with the prednisone, and that's kind of petered off, and he's kind of like leveled out, and even lost a couple pounds, which makes me a little nervous. But for the most part, clinically, he's doing much better. But he's always going to be one of those patients that I'm waiting for the other shoe to drop, like a drug-induced liver injury or something else to arise.
Is he done with his TB therapy?
No, he's actually month 5, I believe.
Oh, okay.
So he's still, and we were going to treat him 9 months with the under the impression. Well, actually, I'm sorry, he's month 6 because he was diagnosed late May, early June, and I'm a 5-6, and we were going to do 9 months treating him as disseminated.
Yeah. Great. And Tivicay and Truvada is what he's on.
That's correct.
Seems to work well. Okay. If there are no other comments or questions, I think we're up to 1 o'clock. Thank you again, Eric, for this excellent presentation and discussion. I hope everyone got a bit of information as far as this topic and can apply it to practice. This will be our last grand rounds for the year. Can you imagine 2020 is over? And we will schedule something for sometime in January. Please just check your emails. We should be sending out some announcements then. Until then, have a wonderful holiday season. Stay safe and mask up. Take care.
Thank you.
Yes, thanks, Eric. Nice job.
No, thank you very much. I really appreciate